And so good morning, everybody, and welcome back to the Journal Club today. Today we'll be discussing, we're on structural interventions today, and we'll be discussing mitral valve edge-to-edge repair. The article we'll be discussing is the EuroSMR registry article from JACC Journals. And the fellow presenting today is Jonathan Curio from Berlin in Germany. So welcome, Jonathan. Thank you for joining us. And I'm delighted to welcome, and we really appreciate Professor Philipp Lurz, a real global expert in this field on mitral interventions. Thank you very much for joining us today. So Jonathan, if I can ask you to share your screen, please. And in the meantime, we'll run the poll for a few more seconds. So please do submit your answers, and then we'll share the results of the poll. So the poll was asking, which patients would you select for mitral valve edge-to-edge repair? And the overwhelming majority of respondents, 75%, have gone for COAPT criteria on echo. Nobody selected MITRA FR criteria on echo, and a few people said either COAPT or MITRA FR. So with that in mind, let's start the Journal Club session, and over to you, Jonathan.
Thanks a lot, Arif. So you're seeing my screen right now, right?
Yes, everything's working.
Perfect. Exactly. So as said by Arif, good morning from my side, first of all, as well. As said by Arif, today we want to discuss mitral transcatheter edge-to-edge repair in secondary mitral regurgitation, especially looking at outcomes according to COAPT and MITRA FR trial inclusion criteria. So to jump right into it, I think you all are aware of these two trials in this field of mitral TIA. So on the left, the COAPT trial with these highly positive results, 24 months heart failure hospitalizations significantly reduced. And then on the right, the MITRA FR trial with these neutral results regarding heart failure hospitalizations and death after 12 months. However, while first there were like this discussion, are these trials opposing? The field now moved to, okay, let's take this chance and combine these two trials to find which patients benefit best from intervention. If we look at these two trials, several differences then came to light. So first of all, enrollment in the COAPT trial, 1.75 patients per center and year were enrolled, and in the MITRA FR trial, 2.46 patients per center and year. So more rigorous screening in the COAPT trial, and it also appeared that the centers in the COAPT trial were a bit more experienced. So comparing, for example, procedural complications, there were 15% of procedural complications in MITRA FR, only like the half, 8.5% in COAPT. The reduction of MR seemed more stable. After 1 year in MITRA FR, only 83% had 2+ or less MR, 95% in COAPT. Now, the difference is the medical management in these two trials. COAPT had a very rigorous committee looking at ideal guideline-directed medical therapy, and patients had to fail GDMT before going into the trial. And then during the trial, there were few changes allowed. In MITRA FR, however, there were changes or adjustments of GDMT during the trial possible. So it was really rather a real-world practice. The sponsor was different, so COAPT was company-driven, and MITRA FR was an academically sponsored trial. One thing that then really got the center of the attention was the difference, the point that is highlighted here on the bottom. So in COAPT, SMR severity, looking at the effective regurg orifice area, so EROA, seemed more severe with larger EROA and smaller EROA in MITRA FR. The ventricles below these mitral regurges seemed smaller in COAPT and larger in MITRA FR. This led to like this concept of disproportionate MR, so a small ventricle sitting below a large MR. However, following like this good explanation of these diverging results by this concept, in like real world registries and practice, this could not really show that it could be a ideal identifier of really better outcomes and patients benefiting most. So how do guidelines incorporate these data? Here are the 2021 heart valve guidelines. Flowchart on the left, for sure. First thing, GDMT needs to be optimized. Life expectancy in severe MR patients needs to be more than 1 year, and coronary artery disease or AS need to be treated first. But then let's look a bit at what we see here at the bottom in a bit more detail. So for sure, always the question is, are patients appropriate for surgery? If not, the question here in these new guidelines is, fulfill patients' criteria suggesting an increased chance of responding to TEER. And then looking really into the supplement of these guidelines, you find the actual co-op criteria, nothing like proportionate, disproportionate, but the co-op criteria. So this is not only small ventricles and systolic diameter below 70 millimeters. This is also systolic pulmonary artery pressure below 70, absence of hemodynamic instability, and also absence of moderate or severe RV dysfunction. And then if these criteria are met, in these patients, you really have a class 2A/B recommendation for TEER. But also if these criteria are not met, there is a 2B level of evidence C recommendation to consider TEER in selected patients, or also consider other transcatheter valve therapies. You see a level of evidence C, so this is exactly the evidence gap where the paper we want to discuss today tries to jump in. So published in JACC with Benedikt Köll and Daniel as first author and Daniel Kalbacher as senior author from Hamburg. The paper is entitled Outcomes Stratified by Adapted Inclusion Criteria, meaning mitral FR or co-opt, after mitral edge-to-edge repair. The paper is based on the EuroSMR registry, being a pan-European registry of transcatheter repair for secondary MR. 11 centers participated, and in these centers, patients were treated with mitral TEER between November 2008 and September 2019. The primary endpoint in the study we are looking at today was all-cause mortality at 2 years, and the median follow-up time was 2.2 years. However, I think it is important to highlight that in this trial, we really had a maximum follow-up of 10.5 years. So also for patients treated with mitral TEER, we are now getting more and more really longer-term follow-up, which I think is quite encouraging. So here's the study flow. 1,600 patients initially were in this registry. Around 650 had to be excluded because they had too few data on the co-op inclusion criteria. 1,022 patients formed the final data set. On these patients, the authors then applied the adapted co-opt and adapted mitral FR criteria that are highlighted here in the middle of the slide. So what does adapted mean? Well, not all criteria that these initial trials used also were available in the registry. So for co-opt adaptation mean that especially previous heart failure hospitalizations, the origin of the MRJet as criteria were not available, and there was no definite definition of the RV dysfunction in co-opt. So here authors used, taking it from literature, a cutoff of 15 millimeters of TAPSE to describe RV dysfunction. Regarding the mitral FR criteria, especially the info on previous heart failure hospitalization was lacking in the registry. On the bottom, you see how these criteria discriminated the trial or the registry data set. So 35%, around 35% of patients were deemed co-opt eligible based on these criteria, 65% were ineligible. Around half of the patients were deemed mitral FR eligible or ineligible. To look at the baseline characteristic, I know this is quite crowded, 2 slides on these criteria, however, or characteristics, however, let me guide you through them. So the co-opt analysis on the left, looking at clinical characteristics, seem to identify patients with less AFib, with lower NT-proBNP levels, and with lower NYHA functional class. Mitral FR characteristics criteria, according to clinical characteristics, as only difference showed lower prevalence of hypertension. Looking at the echo characteristics, interestingly, in the co-opt eligible or ineligible patients, EROA was without difference. MITRA-FR criteria, interestingly, seem to identify patients with significantly larger EROA. The left ventricular dimensions in both groups were smaller than in the actual trials conducted. What was interesting as well was that the co-op criteria seemed to identify patients with better and preserved RV function, lower tricuspid regurgitation, lower pulmonary artery systolic pressures, and better RV-PA coupling, so probably more RV reserve. So how did this translate into outcomes? Here's the 2-year all-cause mortality, so the primary outcome. On the left, the co-opt analysis, and indeed, co-opt eligible patients really had a significantly lower mortality at 2 years. MITRA-FR criteria, however, could not identify a group of better responders. There was no difference between MITRA-FR eligible and ineligible patients. When looking at quality of life, so 6-minute walk distance, Minnesota Living with Heart Failure Questionnaire, NYHA functional class, interestingly, not only in co-opt eligible, but also in co-opt ineligible patients. In all these points, co-opt ineligible patients as well had a significant improvement following mitral TEER treatment. There are several limitations to this study. Sure, it's a retrospective registry. Several data that were assessed in initial co-op trial here were not available, especially information on GDMT, especially on the dosing of GDMT often was lacking while in co-op. As I said, it was quite rigorously managed. The data on quality of life outcomes that I just presented were available only in a small subset of these patients. It is not actual limitation, but I think it's important to state that this is not repeating the co-op trial. This rather takes some learnings from co-op trial, retrospectively applies them to data that we already have and to patients that we treated to better understand patient selection. So in conclusion, adapted co-op criteria in this EuroSMR registry were met by around 35% of patients. And these patients represent a cohort with preserved RV function, less TR, lower systolic pulmonary artery pressure, and lower NT-proBNP. These co-op eligible patients, when treated with mitral TEER, showed significantly lower mortality. MITRA-FR criteria were not able to identify such a cohort. However, also in the co-opt ineligible patients, mitral TEER significantly improved functional outcomes. So to maybe go a bit into the perspectives and maybe also the discussions, questions we could ask were, how should a heart team put these results into real clinical practice? What to do with co-opt ineligible patients? Guidelines state other transcatheter approaches, maybe something like TMVI, so valve implantation. Should there be an open discussion with the patient? Well, probably no mortality benefit, but you might symptomatically improve a lot. Or should there be no intervention in such patients? I think the looking only at this EROA LV perspective probably is not enough to stratify patients accordingly and giving us info on outcomes. These broader co-op inclusion criteria, however, seem to be a quite good identifier of a patient group characterized by like better RVs, lower pulmonary pressures, etc., that seem to benefit more. Is it an earlier disease stage, or is this a specific MR disease phenotype we are encountering here? We now focus a lot on co-opt and mitral-FR in this whole field, but the question could be, what are other trials that we would wish for? 2 trials currently are ongoing, or 2 important trials, Reshape HF2 and the Matterhorn trial, Reshape comparing to GDMT, Matterhorn comparing to surgery. Might these trials explain the co-opt mitral-FR differences? And then mitral TEER, as well as like TAVR, for example, has undergone several device iterations. For MitraClip, we currently have the G4 available. could be interesting to think about these new features that this device offers and do these iterations, as we saw with TAVR, also better outcomes. With that, I would give it back to you, Arif, for some discussion. Thanks a lot.
Great. Thank you, Jonathan. You've taken quite a big and complicated, analysis and summarized it beautifully. So thank you. Wonderful presentation. So Professor Lurz, can I please invite you now to share with us some of your perspectives and some of the key messages from this paper, and perhaps we can lead the discussion from these questions that Jonathan has raised.
Yes, of course. So good morning, everyone. First of all, I would like to thank you for inviting me. I think this is a great format and it's a huge honor to be part of that. And to you, Jonathan, that was a fantastic presentation on a topic which obviously is complicated, and it will remain complicated for the next years, I believe. Also, heads up to Benedikt Köll and Daniel Kalbacher, who put together the analysis and who wrote what I believe an excellent manuscript, because it now provides us with a tool to perform some risk stratification in those patients who are considered for edge-to-edge therapy with functional mitral regurgitation. And as such, it is really something we had not in that quality before. However, that's probably pretty much what it is. It is not a manuscript which can help us to explain the differences in co-opt and mitral FR. It also does not, well, actually it proves that when we're separating patients according to these adapted inclusion criteria, we will not mirror the same population as we've seen in co-opt and in mitral FR. That's very nicely shown on the table. The differentiation between co-opt criteria and non-co-opt criteria does not mean that those patients in the co-opt criteria are actually exactly the same as the baseline characteristics which of the patients who were actually enrolled in co-opt, and the same for mitral FR. And then lastly, with all these analyses, we should not forget that we always compare outcome of two groups which underwent treatment, but we don't have a control group. So be very careful drawing any conclusion stating that when you select patients by mitral FR criteria, you will have patients who do not benefit. There is no difference in outcome because they were both treated, but we do not have a control group. And I think this is very important when interpreting and also discussing these results.
Okay, thank you. So if anybody has any questions, please do type them in the chat, or certainly you can come on and we can ask the questions live. So perhaps we can start, Jonathan, with one of your perspectives or questions, if you'd like to start from there.
Yes, sure. I think one thing that also for me when looking at this trial, again, Philipp, I think also on congresses, etc., this concept of disproportionate MR was around a lot. And I think this is something that also, if you are not that much into this field, stuck to your head, because it always was like the one explanation. Okay, so disproportionate MR, this solves the problem. Just find a patient with disproportionate MR and you'll have it. Could you maybe elucidate a bit on what you think this concept really can offer, and whether whether it can be used or should be used when selecting patients, or should we rather be careful to do that?
It's a brilliant concept, and as you said, everybody jumped on it because it's so straightforward, and it suggested an easy answer to a very complicated question. But it's not that straightforward either. I think that very few would argue that there's a certain point at which the ventricle is so sick, the function is so reduced that fixing MR will not turn the wheel around. The prognosis of patients is pretty much determined by LV function and not so much by MR anymore. And that's something the concept includes, right? It's a differentiation between LV disease and degree of mitral regurgitation. And it is intriguing, and it makes perfect sense to assume that when the LV is not that diseased, it's not that dilated, and there is still some systolic function preserved, but you have a lot of MR, which you can reduce, that those patients are more likely to benefit as compared to those where LV is really end stage and MR is present, but not to a dramatic extent. And I totally agree with that. The problem is, it is perfect to understand differences in two different trials, but for the individual patient, it should not be applied. The ones who described it, Grayburn and also Pecker and Anna Sonano, they made the point very clear that this is helpful if you want to compare two cohorts, but it cannot help you in daily clinical practice, and it should not guide your decision-making going forward with one patient to therapy and then the other one who is denied therapy because of a proportionate MR. And this is due to the fact that ERA is very difficult to measure in the individual patient, and it can vary a lot. There are multiple methods. You can do it by transthoracic, you can do it by TEE, for example. With functional MR, I would argue that when you do a planimetric ERA, you will always get greater values, and I believe that you always get more accurate values as compared to a PISA method on a transthoracic echo, maybe even in limited echo views. So that's the problem with that concept. After the description, many studies try to confirm it or actually prove that it's not helpful. Also studies using the cohort in the Euro registry. But then we and others, we always compared again multiple cohorts who all underwent treatment. And we have not seen difference in outcome, but that does not mean that it still helps to differentiate patient groups who can benefit and who won't, because again, we don't have a control group. So it's very complicated. It's a great idea. It helps to understand different outcomes of cohorts, but it should not be applied for the individual patients in daily routine in the heart team. It can guide you, but it certainly should not be your single decision-making tool.
Okay, that's a nice take-home message. So, any other questions, Evelina?
Yes, I have a question which is more related to everyday clinical practice. Good morning. In my center, I experienced a lot of reluctance from clinical cardiologists to consider mitral clip intervention in their patients with heart failure. And I think this comes from two reasons. The first probably is the past experience with mitral clip intervention, because we have treated in the past patients that probably were too advanced heart failure, also right ventricular failure. So these patients did not benefit significantly from mitral intervention. And I think another reason might be the fact that if you start reading the evidence from the two mitral trials of mitral clip, so co-opt and mitral FAR, you might think there is conflicting evidence. So maybe a clinician may say, there's not such a big evidence about improving my patient's outcome, so why should I consider it? But in reality, we started to analyze more deeply the data coming from the trials and also applying those to real practice registries all over Europe in this case. And so probably we should start also involving more the clinicians in considering the mitral intervention, especially if we perform the intervention before a too advanced heart failure. I would like to know your experience with clinicians and what do you think about this topic?
I couldn't agree more. The uncertainty in a situation where you have two clinical trials demonstrating completely opposite results, and then also slightly different perspectives and approaches, for example, from heart failure colleagues as opposed to interventional cardiologists. Again, I think it's important to stress that in co-opt, all these patients that were discussed in the heart team involving heart failure specialists, it was made sure that they were all on optimal medical therapy. And only after that, patients were enrolled. And that also explains why so many patients had to be discussed to finally come up with a little bit more than 600 patients in that trial over a very long period of time. It was not a fast study. So this is a highly selected patient cohort. And I think that's something we have to stick to in clinical practice. We have to make sure that these patients, that they are on adequate and state-of-the-art heart failure medication, and that other therapies and options are explored before patients are pushed forward to undergo a procedure. When they undergo a procedure, it is important to do it right, obviously, because that's another, for me, that's the most striking finding of COAPT. It's the very first time that we have evidence that when you reduce MR, you save life, you reduce hospitalization. This is the very first time in functional MR. It has never been proven before. The question then is, can you reduce MR also by medication in some patients? Or is the only way to do so the intervention? And that's then a decision within the team. It comes down to clinical experience. And that's something which has to be individualized, I assume, in these patients. But at least for the first time, we have evidence that reducing MR by whatever means improves outcome. I think this is very important. And the other point maybe which should be made, reducing MR means at least to moderate, ideally to mild. And again, that's then a discussion: how experienced are you with the procedure, how familiar are you with the techniques, and how favorable is the anatomy of these patients.
Great, thank you. So let's take a couple of questions from the chat. So the first question is about from Alessandro, who's asking that is edge-to-edge repair alone sufficient? Because some surgical data has shown that if you combine with annuloplasty, you may get some good results. So do we need to start thinking about combination therapies, or is there a cohort of patients where edge-to-edge is sufficient?
Yeah, and if you want to have an outcome which lasts for 30 years, it's probably not. That's for sure. But if you look at the terrible outcome of these patients, we have to provide something for 5 years' time, not for 30 years' time in those patients. And then it's important to understand that edge-to-edge provides some degree of annuloplasty as well. You always get a reduction in AP diameter, and even more so with clip or other transcatheter approaches than with an alveoli stitch, because you pull much more on the leaflets. So it's not an annuloplasty. It would be good to have that in addition, but it provides some degree of annular reduction as well. It's not just edge-to-edge therapy. But combined procedures, yes, it's an option, but it's very complex, it's very long, it's very expensive. I don't think it will be in the future.
Okay, thank you. Then Claudio has got a couple of questions. So the first question is about this concept of different MR phenotypes. So for example, atrial mitral regurgitation. And when we say MR, are we simply generalizing too much and applying edge-to-edge repair to a heterogeneous population? What are your thoughts on that? And the second question he's asking is about optical medical therapy. So when we're faced with a patient in clinic, how long should we try with optical medical therapy before saying, now it's time for your intervention?
Yes. To the first question, yes, we should differentiate. Ventricular functional MR and atrial functional MR, there are two different types of diseases, and they are seen in a completely different patient cohorts. Ventricular functional MR, I think this is pretty straightforward, and we've discussed that. Atrial functional MR, much older patients, they almost always have AFib and HFpEF. Median age in studies almost at 80 years. So there you have competing risks, which makes it maybe sometimes more arguable whether reduction MR really does change outcome. I believe so. It certainly improves symptoms. And in most cases, the intervention is very successful, and you can bring down MR to mild or even less in atrial functional MR. And then to your second question, I think this is a very important point, and there's also some data to back that up. Try to improve medication. If you fail, then consider to fix MR. And after fixing a MR, you will see very often a rise in systolic pressures. You sometimes see improvement in renal function, which will then allow you to add another heart failure medication. So it's not just either or always, but sometimes it's a combination of both.
Okay, so we're approaching time, but a couple of good questions. So clearly a very stimulating discussion. Prof, you've obviously done a lot of work with tricuspid as well. So mixed valvular disease, heart failure patients, severe bivalvular disease. What's your approach? Which valve first? How to decide which valve? How would you even tackle this?
Yeah, so always start with mitral.
Okay.
See whether tricuspid gets better, because when you have a lot of MR, you reduce post-capillary pressures, you reduce RV pressures, and that helps with the tricuspid valve in about one quarter of patients. 3/4 of patients they will remain to have severe TR, and then normally we fix it in a second step. We do it as a combined procedure in very fragile patients, and in those where we see right to left shunting across the atrial septum once we pulled back the guide after fixing MR.
Okay. And the last question, just to finalize, if you have, let's say, an unacceptable result after edge to edge, so let's say you've finished the procedure, you've come out the patient, retrieved the sheath, and you've done, let's say, the echo 3 days later or just before discharge, for example, and the result is unacceptable. What's your strategy then moving forward?
Yeah, you should not accept it. You should discuss other options. You should certainly involve your surgeon. And if the result is unacceptable and the surgical risk is obviously high, otherwise you wouldn't have started with the procedure, but is in some range to be acceptable, then you should go forward for surgery. Because if you leave him with high MR, even higher MR than before, because you had a complication and destroyed the leaflets, then the outcome is terrible. So don't be afraid to stand up, say that it was not the result you expected, but we have to fix it now.
Great. Okay, so we've just come to time. So thank you very much for everybody for participating and coming up with your questions. I think really stimulates the discussion. Jonathan, great presentation. Thank you. You've really summarized a very complex topic very, very nicely and elegantly for all of us to understand. And Professor Lurz, it was brilliant. Thank you so much for joining us.
Thank you very much.
Sharing your insights. We really appreciate it. Thank you.